Thank you, Kenita and Carl, and good morning, everybody. I'm so pleased to be here and to have the opportunity to talk about what is my favorite subject and the thing that I am most passionate about, which is the social determinants of mental health. So I think I have a lot to talk about because I'm here to set the stage, the overview for the work that you're going to be doing for the next day and a half. And so I want to jump right into it, but I do think it's a lot to cover, and so we will take a little break and ask some questions while we go along. This is Emory University Hospital. It's located in Atlanta, Georgia. I had the great fortune to go to medical school, residency, and do my fellowship in community psychiatry and get a master's in public health, all at Emory University in Atlanta. And I grew up in Virginia, and I had parents who were immigrants from Jamaica. And so moving to Atlanta and moving to I was in the South, but moving further south was a bit of an experience for me. Emory is a beautiful institution. It is located in the suburbs of Atlanta. It's located in probably the richest part of Atlanta. And so the people who have the most amount of money and the nicest houses live right here where Emory University Hospital is based. One of the great things about Emory and the training that you get there is that you get a mix of working with patients at Emory University Hospital, but also working with patients at Grady Hospital, which is the large downtown hospital located in downtown Atlanta. Very different from the hospital at Emory University Hospital. So Grady Memorial Hospital is located in the poorest parts of Atlanta, there's a very high homeless population, and very few people have access to any sort of care or services. So I started noticing something really interesting when I got to medical school, but specifically when I started in residency, because we rotated as residents in the inpatient hospital at Emory University Hospital, and we rotated as residents at the inpatient hospital at Grady Memorial Hospital. And whenever I had a patient who was admitted to Emory University Hospital for a psychiatric emergency or some type of crisis, we would treat that patient. We would provide all of the services that we had on that inpatient unit, and they would get better. And we would discharge them, and I'd feel like I'm doing such a great job. I'm making a difference. This is why I went into this field. And whenever I had a patient admitted to the inpatient hospital at Grady Memorial Hospital, we would provide all of the same care, the exact same care. We would treat them, I believed, in the exact same way. We would provide all of the same services, and they did not get better. And I could not figure out what was happening there. If I'm doing the same thing, it's the same crisis, it's the same illness, why is it that some people are improving and my treatments are working, and why is it that some people are not? And so I went on a journey to try and understand that, and that's how I got to looking more at the social determinants of health. So let's go ahead and define them. The social determinants of health, as defined by the World Health Organization, are those factors that impact upon health and well-being, and the circumstances into which we are born, grow up, live, work, and age, including the health system. That's the first part of the definition. The second part of the definition, which we're going to expand on more later today, is that these circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. And there's one last piece of the definition that I like to highlight, and this gets to, again, the answer to why my patients at Grady were not doing as well as my patients at Emory, and that is that the social determinants of health are prominently responsible for the health disparities and inequities experienced both within and between countries. So that explanation for that difference, I found lots of people had tried to understand what is it that leads to inequities, what is it that leads to disparities, but actually the social determinants of health and the social determinants of mental health are most responsible. So I just want to take a minute to define the difference between a health disparity and a health inequity, because there's a lot of confusion around that. So health disparities are differences in health status among distinct segments of the population, including differences that occur by gender, race or ethnicity, education or income, disability, or living in various geographic locales, or other things as well. Health inequity is a disparity in health that is the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. So the difference between an inequity and a disparity is there's no real kind of value judgment on a disparity. It's just a difference. It's just a health difference of some kind. Whereas with a health inequity, there is a moral difference there. It is the result of systemic, avoidable, and unjust social economic policies. And those policies create barriers to opportunity. When I started looking at disparities in mental health, reasons why, for instance, African American males are more likely to be diagnosed with schizophrenia than white males, and white males are more likely to be diagnosed with bipolar disorder when often it's the same condition. Or, for instance, women tend to have higher rates of depression than men, or any number of other disparities, and there's a lot of them. I really started to understand more clearly that none of these were actually disparities. None of these were that the issue was kind of in the seat biologically of the person or the population, that these groups were creating these differences. But in actuality, all of these things were the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And I think we are going to spend some time talking about that a little bit more today as well. Okay, so here's just an example of how the social determinants of health work. This is an example from Health Canada. And part of how to think about the social determinants of health is to think like a toddler. And toddlers often ask why a lot. So if we're going to play the toddler game, we can say, why is Jason in the hospital? Because he has a bad infection in his leg. But why does he have an infection? He has a cut on his leg and it got infected. But why does he have a cut on his leg? He was playing in his junkyard next to his apartment building and fell on some sharp, jagged steel there. But why was he playing in a junkyard? His neighborhood is run down. Kids play there and there's no one to supervise them. But why does he live in that neighborhood? His parents can't afford a nicer place to live. But why can't his parents afford a nicer place to live? His dad is unemployed and his mom is sick. But why is his dad unemployed? Because he doesn't have much education and he can't find a job. And so you see, you can go on and ask why and why and why over and over and over again. And ultimately, the real reason that Jason is in the hospital has very little to do with the infection and much more to do with those social circumstances that led him to be in the situation that resulted in him having that cut. So I'm going to talk about some morbid stuff for a little bit, which is death. And we're going to talk a little bit about what causes people to die early. Because if we're thinking about markers of health and even markers of mental health, I think it's really important to look at kind of the ultimate marker of health, which is morbidity. Mortality. So these are the reasons why people die early, the major determinants that contribute to premature death. And as you can see, there is a piece of that relates to genetic predisposition. So about 30% of the reason why people die prematurely has to do with family history, has to do with if you have a family member with cancer or with cardiovascular disease, you have a higher likelihood of developing that condition. 15% has to do with social circumstances. And as the authors of this particular study were thinking, this relates to the social determinants kind of purely as we have defined them so far. Environmental exposure, which makes up 5%, are things like exposure to toxins in the environment. So very clear things like pollutants, lead, other types of toxins in the environmental milieu. Healthcare makes up 10%. And so that includes not being able to access medical care, but also medical errors. And I think it's interesting that if we look at this figure that 10% of premature mortality is in the healthcare sector, and yet we spend a lot of time and energy and resources trying to improve that particular sector when it's a very small part of what contributes to premature death. And then the overall 40% of the contribution to premature death is behavioral patterns. And behavioral patterns are things like, do you smoke? Do you drink? Do you exercise? What's your diet like? Those types of things. And so if you are thinking about this particular graph in the way that we think about the social determinants of health, I would submit to you that about 70% of this graph is actually social determinants of health. Because often the behavioral patterns, the choices that we seemingly make about whether to smoke or whether to drink or whether to exercise, that many of those things are based on our social circumstances. And there is a statement that David Williams said that the choices we make are based on the choices we have. And so if you have limited options, if you don't have a safe place to walk in your neighborhood, then you're not going to walk in your neighborhood because it's not safe. And then your physical activity decreases significantly as a result of that. So if you think about this, I'm saying 70%, and I teach medical students, and they often are very astute, and they'll say, well, isn't there like things like historical trauma that can actually change your genetic makeup and epigenetics, and how does that work? And I say, well, actually, you're right, and probably it's even more than 70% that actually contributes to this premature death that we're talking about that has to do with social determinants. So just an example, again, I said we'll spend a little bit of time talking about morbidity and mortality. This is Washington, D.C., and this is a map that shows differences in life expectancy depending on where you live. And this map is actually of the metro station in D.C., and I took the metro this morning, and you can see that as on the red line or on the yellow line, there's very different huge gaps in mortality depending on what part of the small area, a very small radius of distance. There are huge differences in outcomes. So 86 years for Arlington County versus 78 years in District of Columbia proper. And this relates to people with mental illness. So individuals with serious mental illnesses die on average up to 25 years earlier than the general population. And then when you ask, well, what are they dying of? A lot of people think, oh, well, of course, suicide and violence and things like that. And that is a contributor, but that's actually not the number one reason why people are dying prematurely of serious mental illness. They're actually dying of cardiovascular disease and pulmonary disease and the very same things that everybody else is dying of. They're just dying earlier. And we just talked about what is the driver of inequities, health inequities that we see in society. And one of the main drivers is the social determinants of health. And so it becomes very important when we're talking about mental illness to focus on the social determinants of mental health as something that may be driving this large mortality gap that we see in patients with serious mental illness. And then this is a report that came out in 2001 from the Surgeon General that just highlighted that there is an intersection here between mental health, culture, race, and ethnicity, and that racial and ethnic minority groups have less access to and availability of care, receive poor quality mental health services, and experience a greater disability burden from unmet mental health needs. So I've been dancing around a concept for the last 15 minutes, and I might as well just kind of jump right into it, and that is the concept of social justice. And so social justice is a philosophical term, and I did not take any philosophy classes at any point in my entire career. So I'm not necessarily the most the best person to discuss this philosophical concept, but I want to take a minute to define it because it relates to what we're thinking about when we think about these concepts. So the distribution of good or advantages and bad or disadvantages in society, and more specifically, how these things should be distributed in society. So social justice is concerned with the ways that resources are allocated to people by social institutions. And this is the definition by David Miller. And if you're thinking about what we said about what inequities are and what drives mental health inequities, we said it had to do with unjust social and economic policies and practices. And that really comes down to how we decide who is advantaged in our society and who is not. And we make judgments on that as a society. We kind of collectively decide which people are worth advantages and which people are worth receiving good and which people are worth being disadvantaged or receiving bad. And then I'll add to that definition another definition by another philosopher, John Rawls, who said that social justice is assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. And oftentimes when we think of people with mental illness and substance use disorders, for a variety of reasons, which we're going to talk about later today, they do in fact end up falling into this category of least advantaged members of society. So one more concept around these things that we are discussing is the concept created by Kimberly Crenshaw about intersectionality. And this idea that you have a clustering of a lot of different experiences that often come and coexist in one person. And we often don't think of the complexity of one person. We kind of see one person. Even in medical school, I was taught to kind of reduce somebody down to kind of one individual, one concept, or one idea. The problem with that is there are none of us that don't have multiple identities, multiple cultural identities, multiple groups that we feel affiliated or connected to. And so when we try to kind of separate those things out or create differences, we run into problems. And particularly when we think about things like racism and sexism and classism and ableism. And I'd just like to add that for people with mental illnesses and for substance use disorders, there's a high degree of stigma, and often you see a collection for people in particular with mental illnesses and substance use disorders clustering around all of these events. And then ultimately you see those differences, those inequities seem to be larger in groups that share intersectional qualities, I would say. Okay, so this is a figure by the Robert Wood Johnson Foundation, and it is describing the difference between equality and equity. And I love this figure because it really just plainly states it here. So a lot of times when we think about healthcare and we think about healthcare delivery and delivering services to people with mental illnesses, we think about fairness. We want to make sure everybody has access to treatment. We want to make sure everybody gets the same kind of care. And that, if you're striving for that, you're gonna meet the needs of the folks at the top. Everybody gets the same bicycle. The problem is it's very hard for everybody to get to the same place when everybody has the same bicycle, because everybody has different needs. And so the goal here is not to strive for equality. The goal is to strive for equity, that every person gets the specific thing that they need to be successful, so that everybody gets to the journey together, but that there will be different needs for different people. Okay. So Carl already mentioned this, but I just want to highlight it again, that the social determinants of mental health are not distinctly different from the social determinants of health. However, they deserve special emphasis because they are highly prevalent, highly disabling, because behavioral conditions are so high cost, so high in morbidity and mortality, and because generally they have largely been neglected in conversations and interventions about social determinants of health. And so it's important that we emphasize these things. So this figure is my colleague Michael Compton and my conceptualization of the social determinants of mental health. And if you start at the very bottom of this figure, this is kind of the things that drive the social determinants. These are things like public policies and social norms, and we'll talk a little bit more about that. And that leads to unfair and unjust distribution of opportunity, which we've already discussed. That unfair and unjust distribution of opportunity leads to the development of these social determinants of mental health. And there's a few of them here. I can spend a minute talking about some of them, but for instance, adverse early life experiences or adverse childhood experiences have been strongly connected to poor physical and mental health outcomes for about 20 years now. And the data is very concerning. The more adverse childhood experiences you have, the higher your rates of suicide attempts in adulthood. And that's actually on an almost exponential scale, so that by the time you have 7 or more adverse childhood experiences, you have a risk that's 30 times greater than someone without any adverse childhood experiences of attempting suicide in adulthood. Discrimination is an extremely strong social determinant of mental health. It actually leads to more problems with mental health than physical health. And those problems, just the experience of perceiving discrimination can lead to higher rates of major depressive disorder, extremely high rates of generalized anxiety disorder, increased alcohol use disorder risk, as well as a number of other outcomes like poor self-rated mental health. We do have enough data to know that poverty and income inequality and unemployment and underemployment often do lead to poor outcomes in mental health. And we have a lot of data around homelessness and housing. We are getting more data around food insecurity and the fact that people with poor access to food tend to have worse mental health outcomes, and particularly for children. Children who have food insecurity often have higher rates of anxiety and higher rates of behavioral disruption in school. So we have epidemic rates of diagnosing children with ADHD and other types of behavioral disruptions in school, but oftentimes food insecurity is the driver of those conditions. And then the environment, kind of quite literally, so the built environment, how disordered your neighborhood is, the exposure to pollution and climate change, we're starting to see more and more data around how those things lead to poor mental health outcomes. Ultimately, we end up with those social determinants leading to reduced options, poor choices. Again, we said the choices we make are based on the choices we have. Behavioral risk factors, physiologic stress responses, and psychological stress. And that ultimately leads to the adverse mental health outcomes that we see. So we're going to pause for a second and let that sink in and maybe take a few questions.
Are there any questions? So I'd like to just ask, we do have a question. Yes.
Speaker on and then speak into it.
Thank you very much. You mentioned that children with food insecurities have a greater degree of mental health disorders. I'm wondering if they have a greater degree of mental health disorders or a greater degree of diagnosis. And I want to emphasize the difference there, because sometimes I think that children are diagnosed with disorders, and it's really more an issue of social determinants.
Yeah, that's a great...
And not a biological disorder or something we can...
Absolutely. So that's a great question, and there's layers and layers and layers of complexity within that question, because to answer it properly, we have to kind of go deeply into the criteria and the diagnosis of the condition of attention deficit hyperactivity disorder. I'm going to just put that to the side for a minute and just say, because the challenge, and I think what makes the social determinants of mental health and thinking about psychiatric conditions so much more complicated, is the fact that psychiatric conditions are filtered through the lens of society. We define them, we create them, a small group of people kind of sit in a room and create the DSM that leads to the diagnosis of these conditions. So and it's usually a common language by which to describe something. So we can't say that these are necessarily, at least ADHD, like a biological disorder. But what we can say is that there is a language of behaviors that is used to define a certain aspect of children who are hyperactive and disruptive in class, and that language is often ADHD. Do those children have ADHD? My thought is that those children who are food insecure are being disruptive in class and maybe being hyperactive and maybe being anxious. And often we are diagnosing that condition without asking about whether somebody has access to food. So I don't know if I can state whether the illness is greater, because that's not what I'm saying. I'm just saying that the behavior is there. And the thing about it is how do we treat attention deficit hyperactivity disorder? We give stimulant medication, right? Which is interesting because it's an appetite suppressant. So we're actually kind of treating a little bit food insecurity when we treat young people with medication. Is that the right way to solve this problem? No, probably much easier to go ahead and address the food insecurity and not go down this route. So I have a lot to say about this, but we can continue to talk about it more as the day goes on.
We have another question.
I just want to piggyback on the last point. I'm from Syracuse, New York, and we've got a major analysis we're doing with community members on gun violence. And in the past 3 years, we've had and 1 year, the highest rate of murders in New York State, which are concentrated in the poor communities, which for us are communities of color because of segregation. And we did an analysis of the third grade reading and math scores on standardized tests and mapped it onto a map of all the gunshots in a 6-year period. And the lowest scores, this is no surprise, were in the schools that had the most gunshots around the schools. We found out that the teachers, when there's an active shooter outside the schools, because this is neighborhood murders, they make the kids climb under their desks. And then when the police say that the person was caught, they say, okay, come on, let's start reading again. So obviously that's part of school failure, but also in those schools that have around which there's the high rate of gunshots, there's the most kids who have what's called disabilities. And when I first looked at that, not being a mental health professional, I thought, oh, that might be mobility or vision disabilities, but it's almost all behavioral disabilities. Right. They use the Vandenberg scale in the schools to diagnose kids who have potential ADHD, but we've talked about it, and we think it's quite likely it's PTSD.
Mm-hmm. Absolutely, and in fact, complex PTSD, which is again, I said, the field comes together and makes a determination about conditions, but that those conditions are filtered through the lens of those experts' experiences, and so if they're not familiar with the type of experiences that these children have, then they're not going to be able to appropriately define this condition. And so there is a lot of movement now to say, okay, there is this complex PTSD that many children in this country face from constant trauma, that is constant exposure to trauma, and that we just kind of generally have not acknowledged that and have not acknowledged the impacts and the mental health impacts of those conditions. So thank you for highlighting that.
Thank you. So we're going to move on. There will be a Q&A session at the end.
Okay. Just a quick check on how much time I have left. I don't have any, do I? Oh, I do. Okay, good. Okay. Wonderful. Okay. So I just wanted to take a second to highlight in my last 15 minutes the piece that drives all of this, so the public policies and the social norms. And so, as I said, there is a distribution of opportunity that's shaped by the laws that we as a society create, and also our own values, the values we put on certain people. And again, it's interesting that we've had these questions, we're focusing on certain children that I think oftentimes as a society, these are children that we have kind of as a society written off. And said that somehow their lives are not as valuable as other people's lives. And then that results in policies and laws and practices that just kind of perpetuate that type of situation. So the pathologist, Rudolf Virchow, said that medicine is a social science and politics is nothing else but medicine on a large scale. And so when we think about how are we going to address the social determinants of mental health, we need to think about public policies and we need to think about laws. So a couple of ideas, and I think we're going to spend the rest of the day and tomorrow thinking more deeply about what we all can do. But I think one of the most important things is to start thinking outside of the medical structure, so outside of the formal mental health care system. And again, I could give another hour-long discussion about the problems with our current mental health care system, but that is not this talk for today. And so instead, I would just say that some of the solutions many of the solutions lie outside of the mental health care system and the formalized mental health care system that we have in society. So starting to think about moving our interventions, while we still need good public mental health interventions, we also need to be able to think about interventions that happen outside in communities, in neighborhoods. And then all of us have a responsibility to advocate for policies that increase or improve all of these social determinants that we're talking about. And another quote by David Williams is that all policies are health policies. And we can extend that out to all health policies are mental health policies. And so when you think about it, all policies are mental health policies. So when we're talking about education policy or employment policy or housing policies, neighborhood zoning laws, all of those things have an impact on mental health. And yet we don't always consider what that impact is before we enact laws and before we enact policies. So it becomes very important for all of us, both in kind of our own communities, but also on state and on national levels, to start thinking about how these policies, how we can help shape policies that really start to address these issues. And related to that, I think it's really important to get political. These are political issues, and if you really want to move the needle on social determinants of mental health, it requires developing relationships with elected officials, or using your organizations to connect with people around policies and laws. And then the most important thing, I think, is forming cross-sector collaboration. So I often find that there are, particularly in my profession, a lot of psychiatrists that tend to kind of want to stay in their group and build work within the field of psychiatry. And I think that's one of the least effective ways to make important strides in addressing social determinants of mental health, because I think psychiatrists have to work with police officers and teachers and lawyers and people in the community, and probably every possible group that you can think of, city planners and every possible group, in order to start thinking about this. And you have examples of communities where success has happened in this place. And so I was just in Atlanta 2 weeks ago and had the good fortune to tour a purpose-built community in Eastlake, Atlanta, which really brought a lot of people from multiple sectors to design a neighborhood and take a neighborhood that had failing school outcomes and the highest crime rates and lots of homelessness, and really turn that neighborhood around dramatically to one of the top schools in the state. People are healthier and and safer, and social determinants of mental health have improved dramatically in that neighborhood. So this is data from the American Public Health Association. When we talk about policies, so a couple of things. We say policies, not programs. We say a lot of people are thinking, what is the program that I can do that will improve these things? But really, it's not necessarily it's a program, it's about laws. And if you look at those countries that spend more money on social care programs compared to health care spending, so things like education, retirement benefits, housing assistance, employment programs, disability benefits, and food security. If you invest in those things at a higher rate that you do your health care spending, people live longer and do better from a health perspective. So again, if you're using the marker of life expectancy, we as a country are not investing in our social care programs the way that we need to be if we're wanting to improve health outcomes. And then the United States is the only developed country that spends, actually only country, that spends more treating health issues versus more on social care. And you can see our health outcomes compared to other countries. And I would just add that prevention programs only get about 3% of US healthcare dollars. So then the last part of this piece is changing social norms. And you know, the public policy part, I kind of feel like that's the easy one. Probably it's not, especially these days, but it feels like it's the easy one. Changing social norms is hard. Changing how people value each other, how we feel about each other, changing and trying to think kind of above maybe our nature, and thinking about how we can connect with people and include people in society is much more difficult. So first, we have to create social norms of tolerance, acceptance, and inclusion. And we have not done a good job of that traditionally. We have examples upon examples of, even in our current day, of how we do really a great job of excluding people socially from society. And so part of that work to build on that is to partner with communities and emphasize inclusion and mutual respect. A last piece related to this is that to change norms, we have to educate and legislate. So some people exclude because they just don't know, because of ignorance, and those people need to be educated. Some people exclude because of hate and because of other kind of ingrained qualities that cannot be educated away. And for those people, we need the laws and policies to help kind of adjust their impact in our society. And then finally, we need to cultivate a culture of social inclusion, and most importantly, speak up when this culture is not respected. So I have started to notice that there are times when people are being exclusionary, racist, sexist, homophobic, transphobic, any number of those things, and a bunch of good people are sitting there as bystanders watching it happen and not saying anything. And I think it's on all of us to be the person that speaks up in those situations. And so I will leave you with this quote from Audre Lorde. When we speak, we are afraid our words will not be heard or welcomed, but when we are silent, we are still afraid. So it is better to speak. Thank you.
Thank you, Dr. Shim. Are there questions?
I just had a comment, Dr. Shim. Going back to the prevalence piece, and I think this relates to the social determinants of mental health and why we're meeting today. Mm-hmm. Because we know in a lot of mental health disorders, we could identify those disorders with tests like fMRIs or with genetics. We could also even, in some cases, simply in EEG identify ADHD or autism. But we don't do those tests. The standard diagnosis for diagnostic process for ADHD is a rating scale where you ask parents questions or observe a child. And I think that speaks to the lack of attention we give and the lack of financial resource we give to mental health. And I just wondered what your thoughts were about that.
Yeah, I tend to agree. I think it's really complicated. So there are some diagnoses where you can do some type of biological test to come close to a diagnosis, but then there's others where there's not enough specificity in the test to be able to be certain of that diagnosis. So for instance, schizophrenia, there are brain changes that happen when somebody has schizophrenia. And actually, it's interesting because those brain changes are different. Some of them happen at birth, and some of them happen as people get older before they have symptoms. Some of them happen when actively they're having symptoms. But they are non-specific changes. So there's no scan that we can do of somebody's brain with schizophrenia and say, this is schizophrenia. Like, I can look at this in the way that we can look at Alzheimer's dementia, and we can find, actual neurofibrillary tangles. We're getting outside of my expertise, but you can find, actual evidence. There is no evidence. And a lot of people are working very, very hard to get there. And so we're moving in that direction. One of my fears, though, is that as we move in that direction, there is a huge push in mental health to biologize mental illness. And I think that's helpful in some respects because it leads to decreased stigma and all of that. But it's also really problematic when you biologize a condition that is conditions that are so predicated on how we interact in our society, how we connect with other people, which is what many mental illnesses, the impact that many mental illnesses have. It's how we move through society. And I think that in moving towards this biological perspective, we've often we've moved away from understanding how social factors and social circumstances have also contributed and how much impact they have on the development of mental illnesses as well.
Are there any other questions?
More a comment. Oops, sorry. I've got my back to you, but I've got to speak into this thing at the same time.
Fine.
So in a former life, I worked with a lot of individuals living in our community with chronic disabilities, for example, post-spinal cord injury from 20 years ago in an urban environment. And what always struck me was when those individuals, because of our education system and the way we silo how we deal with conditions, when somebody with, say, a 20-year-old spinal cord injury was demonstrating symptoms of depression, the assumption by the providers was always, well, that's due to their spinal cord injury.
Right.
Yet these individuals are living in public housing in an urban environment. There are so many other issues. So the immediate response was medication. Like, nobody was thinking about that. And I was struck by the example you gave in the school system, but there are so many examples of that, of individuals living with chronic disabilities in our community, that the assumptions being made. And that's, I believe, the way in which we're educated in the first place.
I totally agree. Thank you for bringing up this question because disabilities is a really important piece. When we talk about, again, the least advantaged members of our society and that idea of kind of who we place value on, again, as a society collectively, we have decided to put less value on people with disabilities. And so you see this interesting pattern. So the way you've described that almost is exactly the way educated people I care about, talk about people with serious mental illnesses. They will say things like, so for many years, people with serious mental illness, part of the reason why I think people with mental illness die early has to do with very, very high rates of cigarette smoking. And for many, many years, there was this idea that you could not, when people would come into a psychiatric hospital, you would not say, oh, this is a non-smoking facility like most hospitals, because there was this thought that people with serious mental illness have such miserable lives that the only piece of happiness that they have is to be able to smoke a cigarette. And so would you deny them the one good thing in their life, this thing that is very, bad for their health? Would you deny them that thing? And to think about somebody in that, to have a perspective of a person that the only thing that matters in their life, to kind of reduce somebody to the concept that their life has such little meaning, when actually, when interacting with people with serious mental illness, it's obvious that their lives have lots of great meaning and lots of value, and most people don't always do that. And I think we do the same thing for people with disabilities. We say, oh, they must live very miserable lives. And so, and you know, of course they would be depressed, right? Of course. So what are you going to do about it, really? And I feel we do that for a lot of mental health conditions. Well, what can you do? They live horrible lives, so it's a really depressing note to end on. So maybe we'll, maybe.
And we're actually just at the top of the hour. One quick question, and hopefully we'll end on a, as you would like, a positive
maybe a happy
note.
question. No.
It's I wouldn't say it's jubilant, but I do have a question. I'm Tracy Moorhead, and I'm with the American Association of Post-Acute Care Nursing. We represent over 20,000 nurses nationwide who are certified directors of nursing services, social workers, therapy, speech, and occupational therapists as well in post-acute and long-term care. We are very focused on developing continuing education that takes into account person-centered care, including, specifically now we're working on trauma-informed care, particularly to address some of the policy issues that you recognized. I thank you so much for your comments, particularly about children, because obviously that does affect the lifespan and the elderly population that our members primarily serve, who are by and large Medicaid recipients. That payer population has a significantly higher incidence of mental illness as well. And I would just thank this forum for the work that you're doing, but also encourage you to consider the role of continuing education providers such as APACN and the many other organizations out there. We are your partners, and we are here to help those practitioners who are in the field continue to incorporate new learning opportunities into their day-to-day practices and healthcare delivery. So thank you for that.
Thank you.
Thank you. Please join me in thanking Dr. Shim.